We wanted to host this webinar to open up a conversation on virtual health and the ways it's been creating change in the healthcare system. So our project, Tele-Rehab 2.0, began with an idea in 2015, and since then has grown into a prototype project, which is poised to begin here right away and change the way virtual care is conducted in our province. So we want to ensure that virtual appointments and assessments are of the same or even higher quality than in-person assessments. And we're doing that through technology and process innovation. So we're set to begin real patient trials in rural Albertan communities here right away in July, and then in several living seniors facilities in the fall. And so one of the major changes that we foresee once the pandemic is over is that the use of virtual health services will drop off again. And so we really want to advocate for the continued use of it because virtual health can help with a number of issues, including accessibility and availability of services. And we really believe that virtual health holds a vital place in the future. And so for this webinar, during this webinar, we want to continue that advocacy work, but most of all, we want to center the voices of the people who are affected by virtual health. So without further ado, I'm going to introduce our first speaker, who is Dana Nagel, who's a mother, and her children are lifelong Stollery patients. So as a family, they typically need to visit the hospital or the clinic several times each week. And so she's going to share a little bit of her story and tell us how virtual health impacted her family already.
Thank you, Emily. Good afternoon. I'm going to be speaking to you all about my experiences with the telehealth and telemedicine and where I hope it continues into the future. I want to thank you all for taking time out of your busy schedule to join us in this amazing opportunity to speak about the importance of telehealth. When I was approached about speaking today, I thought to myself, why would anybody want to hear me speak? I'm just an ordinary mom, and I'm definitely not an expert on telehealth. I'm a mom to 3 children, and I can assure you that I am definitely not an expert on telehealth. I'm just one person that has experiences and benefited from this. I'm a trained Red Seal chef, but after having children, I switched careers to accounting. My husband Richard and I both work full-time so that we can afford all the extra medical needs of our children. Our oldest daughter, Emma, has just graduated from high school and participates and loves musical theater and wheelchair curling. She's in the process of transitioning to adult care as she is almost 18. She has complex medical needs with 2 rare diseases, MCAD and complex mitochondrial, that have never been seen before together. The 2 diseases are completely opposite, and the treatments for them are contradictory, which means that we can only treat the MCAD as it is life-threatening. Our second daughter, Sophia, died of MCAD 13 years ago. Our son, Cameron, is 10, and he enjoys all things Star Wars and Marvel, and loves playing sledge hockey and wheelchair basketball. He was born prematurely and suffers from spina bifida, muscular dystrophy, aspiration issues, and many other complex medical needs. So why does what I say matter? In short, what I say doesn't really matter any more or less than any other family of children with complex medical needs. I am just one opinion to hopefully advocate for the continued and proper use of telehealth and telemedicine appointments. Our experiences with telehealth have been quite positive. While both of our children are neurotypical, they struggle daily with mobility, motor function, and other issues that arise from having a medically complex life. As you can imagine, we see many different specialties and have spent many hours at appointments. You see, part of the reason why I changed my career was because it was not flexible. If the kids had an appointment or had to be hospitalized, I would not be able to rearrange my schedule on short notice. Working full-time is a challenge when you have one medically complex child. Throw in another medically complex child into the mix, and it's a bit chaotic, to say the least. The amount of time that it takes us to get to an appointment, find parking, get the kids situated in their wheelchairs or walker, pay for parking, and get up to the appointments, and sometimes we're already at an hour and a half. Sometimes we will have more than one appointment a day, say one at the Stollery and another one at the Glenrose. Or sometimes one child has an appointment at one hospital and another at a different one. As you can imagine, the time missed from work for both my husband and I, as well as the time missed from school for our children, have become significant. We have always lived outside of Edmonton, first in Kalmar, about an hour's drive to the Stollery and an hour and a half to the Glenrose in perfect weather and not rush hour. We now live in Leduc, which is about a 45-minute drive to the Stollery. There have been many days of missed work, school, field trips, gatherings, and just plain old fun with friends and family due to the mounting appointments. A day in our life with appointments consists of something like this. For an appointment at 11 in the morning when my parents can help us, I will go to work very early. I usually leave around 3:15 to start at 4 a.m. My husband would do all of the medical care in the morning for the kids and get them off to school and go into work late, which would mean that he would then have to work later into the evening to make up the hours. My parents would pick up whichever child had an appointment at school and drive them to the appointment. I would leave work about 10 o'clock in the morning to drive to the appointment and meet them and find parking. We would then go to said appointment and always have typically a longer wait for the doctor or clinic appointment. Some appointments, we may see many doctors, nurses, and specialists. They can last up to 4 or 5 hours. By the time we would get home, it would be late. We would eat a quick supper, and then I would have to log into work to make up the time I'd missed, while my husband then deals with all of the meds, medical procedures, and bedtime. I would work until 11 to 12 o'clock at night, fall into bed, and get up the next morning to do it all again. If my parents weren't able to help, we would either need to make the choice for me to go to work and then drive back home to get our child from school to make the appointment and waste the fuel and wear and tear on our vehicle, or for me to work the weekend and more nights to make up the lost time. I'm extremely lucky as my boss is very flexible and I can do my work from home if I need to or any time of the day or night. The problem is that this takes away so much time from our family. There are times that I can only FaceTime the kids to say goodnight from work, and I don't get to participate in family game night or reading the story before bed. While I am in no way complaining, it does make for a difficult situation for our children who only want to spend time together as a family. Next slide, please. For our children, the time missed from school for so many appointments have its effects as well. When you miss that much time in school, you are bound to be behind in schoolwork. We have spent many weekends catching up from the work that was missed throughout the week, and we've spent thousands of dollars on tutors for the last 7 years because our daughter Emma has missed so much time. To put it into perspective, when she was in grade 9, out of 127 math classes, she missed 76. That was more than half. Her teacher couldn't believe that she had passed, but she had put forth so much more effort than she really should have had to because she was bound and determined to graduate on time with her friends and her classmates. Cameron has missed out on numerous field trips because we just could not make it back in time from the appointments. While he has just finished grade 5 and is catching up is much easier at this age, he has missed out on many recesses, gym classes, and out-of-school activities to catch up on his missed work. Since 2007, when Emma was first diagnosed, we have miled out 4 vehicles and spent tens of thousands of dollars on fuel, parking, and vehicle maintenance. Just last year, we spent over $6,000 in parking fees. This is not including the amount that we were reimbursed from FSCD. We had not used much telehealth or video conferencing until the pandemic began. My daughter Emma had only ever used it once while she was enrolled in the Pain 101 class, and we were unable to get to the Stollery for it. During the pandemic, a lot of our appointments turned into telephone and video conferences. At first, as with anything new, we were a little bit unsure. We'd always seen our doctors and clinicians face to face in an office. But as the days and weeks went by, with more and more of our appointments being changed to video conferences, we realized that this could play a significant role in changing our lives. Not having to take the extraordinary time off of work to drive to and from the appointments, pay for parking, fuel, and wear and tear on our vehicle has made a significant change in our life. I'm not having to make up even a quarter of the amount of time of work as I did previous. There have been no more waiting in an examination room for extended periods of time. The doctors and clinicians have always been on time, and the times for appointments seem to be a bit more flexible. We've been able to book them for later in the day or earlier in the morning to minimize the time missed. My daughter made a very profound point to me when I told her about this presentation. She said, "I don't understand why it took a pandemic for this type of thing to be looked at more mainstream. How many times did we go to an appointment, wait for over an hour for the doctor to talk about the need for an upcoming surgery, propose a medication change, to ask how a new medication is working, or to get the results from a test or a recent surgery?" She said this would be perfect for that type of thing. I wouldn't need to have a physical exam, and they can see me right through the screen. I could have kept up with my physio, where they could make sure that I was doing the exercises correctly, and only go to the clinic less frequently. My dietitian and I could have talked about my sugar lows and new ideas on how to prevent them. And you know what? She's absolutely right. Our family has had such a positive experience with telehealth and video conferencing appointments. The only challenges that I could see are making sure to have the technology available in some of the more rural areas, as well as with families that are low income. I have also come to learn that doctors and clinicians, or that some doctors and clinicians love telehealth and video conferencing, while some much prefer the in-person clinical visits. Some families will definitely feel that they need to be seen in person for all appointments and will not want telehealth or video conferencing. I feel like the buy-in from some professionals and families may sometimes cause a challenge. Next slide, please. So what do I believe is the future of telehealth? I absolutely believe that telehealth and telemedicine is headed to become more readily available. When I was talking to Emily, the wonderful woman putting together this webinar, she was telling me how they had started using telehealth for things like running seating clinics for custom seating in wheelchairs. She was telling me that the client would go to a local physio clinic and the physiotherapist would use telehealth to connect with the healthcare provider, and they could help take the measurements and ask the appropriate questions. I was absolutely astonished. We had chosen to not have our son be seen at the seating clinic because it was to be an 18 to 24-month wait. He had already outgrown his wheelchair and he could not wait another 2 years for a custom seat. We chose to just make do and basically rig something up in our own way so that he could be more comfortable. It's not ideal, but it's what worked for our family. The thought that this is the future and could possibly make wait times go down would be a huge step forward, and this is just one example. I think that telehealth and telemedicine is the new wave of the future. It will offer people in remote areas equal access to healthcare without traveling such a great distance on a regular basis. I know of many families that come from Northern Alberta and use their vacation time and money to attend their appointments. While some in-person appointments absolutely need to be continued, they have also voiced that some of the appointments could be done by telehealth or telemedicine. This would mean they could maybe only come down once a year instead of multiple times. I think in the future, the use of telehealth or telemedicine may be able to lower the costs to both families and clinicians. I believe that it will become more mainstream. Doctors, clinicians, therapists, and families will all be more open to the idea of a new way to access healthcare. So do I think that telehealth and telemedicine should continue post-pandemic? Absolutely yes. While I completely agree that there are some times that in-person clinical visits need to be accessed, I think that we could find a healthy balance between in-person clinical visits and telehealth. Definitely brainstorming for future procedures or interventions, following up appointments for blood work, refilling prescriptions when everything is stable, some rehabilitation follow-up, and mental health supports would all be good examples to use telehealth in the future. I know people that have accessed mental health supports during the pandemic because they did not have to go into a clinic. Whether it was because they did not have transportation to an appointment or because they were too scared or uncomfortable to meet someone face-to-face, telehealth and telemedicine could be life-changing and life-saving. Thank you all for your time today. I really appreciate the opportunity to have been able to give you all one family's perspective on the telehealth and telemedicine.
Okay, awesome. Thank you so much, Dana. We really appreciate you sharing your story with us. And it's hearing the stories of patients and families. It's really vital to us and to the project as we continue to advocate for virtual health post-pandemic. So thank you so much. So I'm going to introduce our next speaker. So we're now joined by Dr. Adalberto Loyola-Sanchez, a physiatrist who has been working on telehealth initiatives here in rural Alberta, but also in Mexico during the pandemic, but also before. And so he's going to share his experience with us with virtual health as a clinician.
Thank you, Emily. Can you hear me?
Yes.
Good. And thank you very much, Dana. Thank you very much, Dana. That was very, very good. So thank you for sharing that knowledge. It's really inspiring for someone like me to know that the value of telehealth. So I don't know, do you have my slides or do you want me to share?
They should be, yeah, you can share them. Sure.
I can share them? Let me try. Oh, I'm disabled. I
Oh,
can.
okay. Here, we'll get them.
Okay.
There they go.
Perfect. Okay, so thank you very much. So I'm going to do something similar as Dana. I'm going to share my personal perspective. So what I want to communicate today, I need to put my timer on because sometimes I just go. So I want to share with you about my personal experiences doing health. So can you go to the second? Yeah. And the second one is I will end with some reflections about what other clinicians in the field of rehabilitation have been expressing using telehealth during the pandemic. And as just as the spoiler, I think the conclusion is very, very similar as what Dana just shared. So let's the next one, please. So let's begin with this story. I'm going to share with you my story of working with a Mayan community in Southeast Mexico, very near to Cancun. I'm sure that most of the audience here knows where Cancun is. And this is a very poor Mayan community, it's a community of low socioeconomic status. And we developed a community-based rehab program there for people living with musculoskeletal diseases. But we entered there as researchers, right? And then they told us, okay, that's good, you can do research, but you need to provide those services, right? Otherwise, what's the point? So that was kind of the first, it was kind of like a moral obligation from my end to start practicing as a physiatrist in this area. So we said yes, of course. So I did that along with a group of rheumatologists, and we started with the assessments, right? So we went there, we did assessments, and then we put management plans. And at the beginning, it is like in the picture you're seeing there. This is a patient that we were going house by house. This is inside the house of one of the persons there, and that was it. That's go there, do the assessment, and try to communicate with the family member there in Spanish, because of course this person didn't speak Spanish. They speak Mayan, and try to tell them what do you think and what should be the recommendations. So it was very, very frustrating. So at the beginning, and I spent a year doing this. I went to live there actually for 9 months. And the most frustrating thing of all this is that, first of all, I was not from there. I don't speak the language. And second, there was nothing around. So I'm sharing you this story so you can get a sense of what I'm talking about. There is not even an idea of what rehab means or disability, etc. Can you go for the next one? So this is, in this slide, I want to tell you the story of how we evolved. So that frustration kind of pushed us to be more innovative and more innovative. So we started with, okay, so let's try to do it more structured. Let's do face-to-face, right? As I told you, alone. But let's structure the assessment. Maybe that's what we need, just a structured way that then the patient or the person could understand what we were saying, and maybe they could actually do what we were recommending. But guess what? Nothing happened, right? Like every time that we came back, they haven't done anything that we said, especially like exercise prescription, which is something easy to do in these settings, easy to teach it, or at least to communicate it, but it's not easy for people to change their behaviors and do that, right? So then we migrated to the idea, okay, so let's work with people living in the community who speak Mayan, who know the culture, and try to work with them so they can help us to do the assessments and help us to monitor and support people to actually do the plans that we were doing in terms of rehab and rheumatology. And so that's why we created a community liaison. So this greatly improved things. However, what was the main issue? The main issue is that we started going in a less frequent basis to the community. So we relied on doing 3 to 5 visits a year. So we went from every week to 3 to 5 a year to 2 a year. And when we spaced that, yes, the community liaisons were great. However, when we went back, we didn't find that people were doing the plans and were understanding the plans. So there was something missing there, and that's when telehealth came into place, right? So the problem here is the distance. So we cannot travel thousands of kilometers just to see people in person, and hoping that by our mere presence, they're going to establish a relationship with us, they're going to understand where are we coming from, and we are going to understand them deeply. So that's when telehealth came into place. And this is Mexico, so you will see that we grabbed whatever we had available. So we started using Skype, the regular Skype, and WhatsApp to communicate with the community liaisons, to see people through Skype, and to do knowledge exchange activities, like you see in the picture there, with community, like community members, in order to improve that communication, so to deliver the services. So on the top you can see that's a rheumatologist in Mexico City giving and on the left side he's giving a consult or having an exchange with people in Chankom in my community. The big limitation in this setting, on top of everything, is that the very low quality of the internet signal. So it is very frustrating as well, but it was much better because that brought us closer, right, in a more virtual way. So that way we were able to see people more often and to solve issues as they were emerging, kind of like within that same week. Before, they just waited for months for us to come back. So that was a big lesson learned. So now the next one, please. The next one is about, now let me talk to you about my experience in Edmonton. I work at the Spinal Cord Injury and General Rehab program at the Glen Rose. So when I arrived to the Glen Rose, I found that there is this program, is called Telehealth Outreach Program, which we have already the technology to connect within Alberta Health Services with rural areas and remote areas through clinics. And of course, that was very appealing to me, and started using it a lot for people living outside of the Edmonton area. So that was very interesting. And I was doing, on average, before the pandemic, on average, 2 visits per week. Can you go to the next one? Now, during the COVID-19 pandemic, 90% of my outpatient services are via telehealth. And interestingly, not through the telehealth platform, because as you know, like all the rural areas are closed, and some hospitals are closed, and we don't want people to go to their clinics as well. So locally, Alberta Health Services approved the use of Zoom. So now I'm doing these visits in people's homes. So that has been a big change. And for some people this is not very comfortable. So I do it through phone, right? So next one, please. So my individual impressions so far, is there are advantages and disadvantages of the use of this. So the advantages right now are like avoids travel times. It's echoing what Dana is saying. Good way to identify urgent medical needs from my perspective. So I could contact easily with people to see, yeah, this is a problem or not, and improves a concept that is called continuity of care. So relational continuity of care is that concept of establishing long-term partnerships and relationships with patients, right, between clinicians and patients. So that helps because it makes it more accessible and more easy to communicate. As for the limitations, going again to the concept of continuity of care, the way things are right now, there are low levels of management continuity of care. Why? Because the system is not well connected. So I don't have a good communication with health providers who are outside of the Edmonton area. And this is not the fault of the telehealth technology at all. It's just the system. But telehealth poses a great opportunity to reduce this this limitation. And of course, the big one for me is having reliable assessments to inform my clinical decisions. That for me, it's a huge one. Next one. So now I'm going to jump. So this is just a new paper that came out in 2000, like a week ago or some weeks ago, about what are the important recommendations when you do virtual connections with patients. So I'm just putting it here. One is be present. So be present means we need to optimize that virtual space for the encounters so we can actually develop these connections. And that is highly dependent on the technology. That's where I see this, the project and the program of research of Tele-Rehab 2.0 being very, very important. And the Tele-Rehab 1.0, which I'm sure Martin is going to explain. But all of this, could contribute to make a virtual space that facilitates that being present, which is one of the principles of the recommendations. The other ones is kind of more like you identify the needs, you listen, you respond with empathy, and you share information in small bits. Because right now, for example, I'm talking to myself. I just see Emily here. So it's very hard to lose. It's very easy to lose the track, and you just start talking and talking and talking, right? So it's important to learn how to do this virtual etiquette. So next one, please. And now let me finalize. There was another virtual health innovation that we are creating because of the COVID-19 to bring the community of people with spinal cord injury closer to clinicians, and it's the creation of the Alberta Spinal Cord Injury Learning Seminar. So we are holding this every 2 weeks in this format of a webinar. People with spinal cord injuries invited, so they attend, and we talk about different topics. And this is in collaboration with community organizations. Next one, please. And I just want to present you this because this is important. So this is, we have a neuroscience rehab ambition strategy clinical network in Alberta Health Services, and they did like a small survey, a small exploratory analysis about what those people in rehab, like professionals in rehabilitation, are thinking about this experience of using telehealth to provide services. So this is part of the results. So as you can see, in terms of patient experience, so patients are saying yes, saves money, time, it's more comfortable being at home, safer traveling, all the things that Dana already shared with us. In terms of outcomes, they feel that it's a better, accurate representation of the visit. And this is very important for us in rehab because we're dealing with function, and function for us is what you can do in your real life. So telehealth or tele-rehab can help us to access those spaces of where people actually function that we are not used to access, because we just bring people to our own environments in a clinic, which is kind of artificial, right? So this is a very important thing, and reduce wait times for services. In terms of provider experiences, so some people said that it saves times, it's more efficient. They have the option of multidisciplinary, improves multidisciplinary connection, which for me, it's a gap. It was a gap of what I'm experiencing now. So hearing this telling me it's not the telehealth issue, it's more the system issue, and telehealth can help us to improve that. One Zoom call replaces multiple calls or emails and improves collaboration. And in terms of costs, well, there is no doubt it's cheaper for patient, for provider, for the system, right? Frees up office space and improves people. Some people say improves my statistics because I can see more people in less time, right? So it makes somehow more efficient. Now, the next one, please. Let's talk about the challenges and opportunities. So the opportunities they feel is that there is now a chance to develop guidelines of how to do these encounters, how to do these virtual assessments, to validate assessments, right? To increase regional communications, and to create new ways of doing multidisciplinary work. And in terms of challenges, as again, this maps with my own perception, which is the hands-on assessment and the treatments are still very limited. Just through a Zoom call, I cannot do a good assessment of strength or muscle strength or or range of motion. I cannot even prescribe a specific exercise, etc. Right? The technology and connectivity limitations, even here in Alberta, we have those, right? In Chankom, in Mexico, it's worse. And we need to validate outcome measures. So this is interesting. So in a nutshell, next one, please, is my last one. So to conclude, I'm saying what I feel, what I think personally, and by hearing and analyzing a little bit what other people think in the field of rehab, is that Tele-rehab is here to stay after the pandemic. I think that's no question. We will continue doing this. Now the question is, how are we going to improve this? Then the COVID-19 pandemic is a catalyst and has been a catalyst for this to grow. And there is a huge need to develop virtual technology to improve these virtual spaces, allowing for reliable and valid assessments and treatments. So by this message, or with this conclusion, I will proceed with the next presenter, because he, as you know, Martin, has been a visionary in this thing. And I remember when I met him before I got into this position, he told me his vision about having kind of like the Star Wars technology of how they communicate in Star Wars with holograms, and you can assess. And when he told me that, I thought, well, that makes a lot of sense, right? And now I think with this pandemic, this is a catalyst that may push this forward. So this could be come true. So this dream of his come true. So I'm really excited of hearing what he has to say.
Awesome. Thank you so much, Adalberto. So sharing your positive experiences with virtual health as a clinician is really great. Can encourage other clinicians to keep going with virtual health as well. And as you mentioned, I'm going to welcome Dr. Martin Ferguson-Pell now. He is the principal investigator on the Tele-Rehab 2.0 project, and he has worked tirelessly to curate and to create technologies so that we can provide affordable, quality remote assessments. So welcome, Martin.
Thank you, Emily, and thank you, Beto. And thank you, everybody, for coming today to listen to this webinar and to get an update on some of the work that we've been doing. And I think sharing in this incredibly exciting time that we have in looking at the future of telerehabilitation. So I wanted to just give you a very brief background to say, well, how did we get here? And as Emily said at the beginning, around 2015, we began to create a vision for what we felt we could contribute in building a new model for telerehabilitation. And we called it Tele-Rehab 2.0 because we wanted to contrast it with the traditional video conferencing way of conducting telehealth and look at what could we do to push that envelope so that we can do some really daring things in terms of the complexity of assessment by having technology help us. And so in 2019, in January, we were fortunate in receiving funding from Alberta Innovators and Pfizer as part of the work we do with the Smart Network at the University of Alberta. And we got things moving, and we had 2 years to make a dent on this question of what opportunities are there for technology to improve telerehabilitation. And we're now at 18 months. And so the technology has come together, and we are tomorrow hitting the road and deploying this in rural Alberta, 3 rural sites, and as Emily was describing before. Next slide, please, Emily. So the big question in my mind is, why has this taken so long? What are the barriers to trying to use technology in more complex and sophisticated ways? And why suddenly has that changed? And so as a biomedical engineer, I guess I pride myself in trying to put a lot of effort into making sure that the technologies we're involved in developing are really responding to the needs of clinicians and patients. It's very tempting and very easy for me as a sort of biomedical engineer technologist to dream up fancy gadgets. But if those gadgets are not compatible with what we need to do in a clinical setting, especially in a rural setting, then they become something that essentially gathers dust on the shelf at the end of the day. So we were committed right from the beginning with this project to make sure that the technologies we started to develop as our bundle of technologies to take to rural Alberta were ones that our clinician colleagues and patients felt would be useful and practical to use. So using the current terminology, this was a co-development project that involved both the clinicians and also the technologists who've been trying to build the solutions. And what we learned very early on was that this is not just a technology problem, but it's also a process problem. In that, as Beto was saying, part of the issue is how it works within an existing system. But beyond that, even when you have kind of connected to that system, whatever it is you're using to do an assessment needs to follow something that we've called a storyboard. And so if you could imagine, if you were in the movie industry, what you have is you have the actors, you have the sets, you have the technicians, the audio people, and so on, the key grip. And what you ultimately do is pull that together using a storyboard to produce the movie. The movie being the final product, which is this nice, smooth, compelling outcome that you're trying to achieve. And that's what we felt was absolutely necessary. It was a fundamental of what we were doing, in that at the end of the day, we did not want these technology solutions to take a lot longer for a clinician to deliver than if they were doing it in a face-to-face assessment. And we were not looking for a technologist in the closet in rural Alberta who's going to jump out every time something goes wrong. We needed to have solutions that would work when we were 5 hours away. So these were all the challenges of why it's difficult to get something like this truly deployable. So one of the other things that has made a huge difference, I think, in terms of being able to take these technologies forward and now use them in a practical way, is that there's been a revolution in a lot of technologies that are associated with a number of changes. Some of them are associated with cell phones, some of them are associated with gaming, but what they have done is produced easy to use, very low cost technologies that we're all kind of now familiar with. So technology has changed in the last few years, and I would say around about 2015, 2016, we got to this magical point where we could see these things coming together in a practical way without having to do a great deal of bare bones technology development. And so, as I'll be describing in a few minutes, what we've been able to do is to put together some technologies that are just commercially available and use them in a different way. And then some developments, some technologies we've had to develop to make them work for this particular application area. So the focus of what we've been doing is quite broadly defined. So there are 4 areas we work on at the moment. One is for people who have vertigo or dizziness, people who have a shoulder problem that is really a significant painful problem or an instability of their shoulder. The third one is for people who have had a hip or knee replacement and are needing to be followed up at periodic times to make sure that they're progressing well. And finally, probably the most technologically challenging and actually in many ways one of the most rewarding is the one where we're trying to provide wheelchairs and special seating assessments to people in rural Alberta where there's a huge need and a shortage of expertise. So those are areas we've worked on, so quite diverse, and essentially put together the technology packages and processes necessary to be able to do those assessments. So what I should point out is that one of the goals of this project was to not do this in the person's home, because there are certain limitations to doing assessments in a person's home. Some of them are to do with the technology they have in their home. And secondly, they're to do with safety, in that there are certain things you do in a rehabilitation assessment that really need to have someone to spot the patient or help them, support them. And also certain assessments that you do where you need another person present in order to provide information back. So as you can imagine, what we have then is a simple clinic setting with a bundle of equipment that we have delivered, a generalist clinician who is able to be coached through the assessment through a specialist clinician based in a hub location like Edmonton or Calgary. And so this setting enables us to do more complex assessments than we would be able to do if we were working with someone in their home. But what this assessment can do is to help us find a pathway for this patient so that that then can be delivered to them when they go home, and maybe the follow-up could be done using more traditional Tele-Rehab 1.0 kind of technology for the follow-up and the ultimate long-term care of that person. So this is an example of the sort of thing that we're doing, just to give you a flavor for it. So the bottom left-hand side of the slide shows you our lab, which is a very fancy lab with about 21 cameras, rather like Pixar uses, which enables us to make measurements of body movement. And we conducted a lot of studies involving wheelchair propulsion. In 6 months, we were able to take the technology that was used in that lab to technology that could be used in a rural clinic, where a $250 camera is able to essentially look at body landmarks and using artificial intelligence, identify where those landmarks are and how they move over time. And this gives us information about functional movement, whether that's functional movement with someone with a shoulder problem or someone who is a wheelchair propulsion person or someone who is maybe walking and has a gait limitation. So this technology enables us to do this in a very simple way. You switch it on and it makes the measurements for you. It can also do balance measurements that are very helpful for us for patients who have a vestibular problem, a balance problem, and maybe dizzy or maybe at risk for falling over. Next slide, please, Emily. Another thing we found incredibly helpful, and our clinicians latched onto this right away, is this robot called a double robot. And it's essentially able to balance on its 2 wheels and then move around under the control of the person in the hub location. So in other words, in Edmonton, we can make this move around in Peace River. And what it enables the clinician to do is have a presence in the rural setting. So the Edmonton-based clinician is shown on the screen of essentially the iPad and is a point of interaction with the patient, which personalizes the relationship much more than you get with a webcam, which could be at the other side of the room. Also, it can move around so that the hub clinician can look at different aspects of the patient that may be involved in part of the assessment, or they can stand back and look at their walking or move up very close and look at their eye movement. So all of these things are possible using this technology under the control of the hub clinician. Next slide, please. One of the interesting challenges, and I'm so pleased to see Andrew on the call today. Andrew is from Australia. He was an intern with us and he helped us with this project. And what we thought was challenging was, how do we know how much force a patient is able to exert in a remote location, because we're not there to feel that force? And so is there a way of communicating a force that the hub clinician can pick up and use as part of the assessment? And so what we decided to do was to actually use the clinician's muscles as a way of detecting how much force the patient was generating. And so we can use EMG, which is a way of measuring electrical activity of the muscles, to calibrate the EMG signal against the force that that clinician is experiencing when they push against the patient. And the sort of thing you're looking for is how symmetrical. Is the right hand the same as the left hand? The right knee the same as the left knee? And so what we want to be able to do was to transmit that force information from the remote location to the hub location, and to do that wirelessly, really inexpensively, and an easy way to do that. And so, as you can see in the bottom right-hand corner of this slide, you can see the force variations that are occurring when the remote clinician is pushing against the patient, and that's giving us an indication as to how strong the patient is on that side, and it can give us information about how symmetrical they are. Next slide, please. So I think we've heard a lot of the good reasons as to why we need to move down this path, and I don't want to give you the impression that all of the problems have been solved. Beto mentioned some of them. We're not sure about how to manage the necessary bandwidth that we're going to need as we develop more and more complex solutions. We need the technologies to be reliable and not require a great deal of additional support in order for them to be used seamlessly. That probably means that we need to provide some training for people in remote locations to become adept users of tele-rehabilitation technologies. Not to say they have to be an engineer, but just to say a little bit of training that could be provided over a couple of days to enable them to be able to reliably use it. And so there is no doubt for the kinds of problems that we've been looking at, the 4 modules we've been looking at, there are very few specialists available in rural areas. So what value we're adding to this process is to be able to connect a patient to a specialist who would otherwise only be available to them if they can make the trip down to a center like Edmonton or Calgary. As you've heard from Beto, this can reduce the burden on the healthcare system, improve efficiency, and also what we found so far in the conversations we've had with our rural colleagues is that it enables them to upskill over time. So after they've done an increasing number of these kinds of assessments with the support of a specialist clinician, say in Edmonton, they become more confident in being able to do more complex assessments themselves because they've had that support. And so these are some of the benefits we see. One of the most important ones for me is that because we're having to transmit information from rural to urban Alberta, we're actually transmitting data. And this is data that is sometimes, in fact, mostly not collected in a face-to-face assessment. And so in rehab, we have a shortage of good quality evidence to back up some of the treatments and procedures and assessments that we use. And the reason for that is we just don't have the same data collection systems that you would have in an acute care setting. So by virtue of the fact we're having to transmit data from A to B means that we're collecting data. And that means we can start to generate evidence. Next slide. And so as you can see, COVID has made the big difference because suddenly virtual care has exploded and the barriers have come down. The perceptions that there were problems with using it, like what are the privacy issues, or what is the patient acceptance going to be, or is it as good as face-to-face, or is the bandwidth going to work? And what we've done is we've had to make it work, and suddenly we've been on this accelerated course that I'm hoping we can now sustain. Next slide. So absolutely the most important reason I think for doing this is around equitable care, in that without a doubt, people in rural Alberta are not getting access to the same quality and scope of care in rehabilitation that people in an urban setting get. But even now, as we've seen during COVID, people in urban settings now find themselves less able to get out and access these kinds of services. So equitable access, regardless of whether you're an old, fragile senior who is really vulnerable to come into a clinic setting, or whether you're someone living in rural Alberta who can't make the trip down because you have a vestibular problem that makes you chronically seasick because of dizziness that you're continuously feeling, these barriers can start to be removed. Next slide. That it? At the last slide? Oh, okay, I'm sorry. I didn't know what my last slide looked like. So that's the story as I see it. It's a work in progress. We're very excited to keep this going. And we're very keen to continue to develop this program with our clinician colleagues and capitalize on the momentum that we've suddenly been, it's like riding a wave. It's like surfing. Suddenly we've hit the big wave and we now need to keep this going so that we can really derive the benefits that we've just been describing this afternoon. Thank you, Emily.
Awesome. Thank you, Martin, so much. So we have about 8 minutes left. So now that concludes the speaker portion of the webinar. Now, so we're going to take some questions. So you can ask your question by typing it in the chat. And we might not be able to answer every single question just for the sake of time, but we are more than happy to follow up with you after the webinar if you would like. And I just wanted to say thank you all so much for attending our webinar and for your interest in virtual health and in our project. And if you would like to get involved more with the project, we have 3 ways that you can do that. So you can share your story like Dana did, you can collaborate with us, or you can join our team. And so we just really want to ensure that healthcare is as accessible as it possibly can be. So you can visit our website, which is Tele-rehabilitation-collaboration.com, kind of a mouthful, but then you can go to the Get Involved tab and connect with us over there. So now we'll see if we have any questions coming in. Okay, not any questions so far, but lots of thank yous to Dana for sharing her story. So yeah, thank you again, Dana. Okay, so I have one here. So are there any foreseeable legal challenges related to telehealth? So I guess, Martin, did you want to take that one?
I'll give it a try. I'm not a lawyer, but obviously the sensitivity is around privacy. And what I would say is that Alberta has a reputation for probably being the most rigorous province in Canada for managing privacy in relation to healthcare. So that would be the first one. The second one that has arisen when you start to deliver care across provincial boundaries, in that there are restrictions in being able to deliver care across boundaries that have been in place for quite a long time. And I think that one of the things we may see is some relaxing of that, but there will need to be some legal measures that are taken in order to enable clinicians to deliver care not only across provincial boundaries, but I think across international boundaries at all. Because think of the democratization opportunity we have to be able to provide care which is highly specialized to people living in rural settings which may not have access to that same level of care using this kind of technology. So those are two that spring to mind.
Awesome, thank you. I have another one for you. For physiotherapy, is an EMG measurement interpreted as a muscle strength, or would it stay as an EMG measurement for a patient's file?
Yeah, that's a good question, because I think if I'm interpreting the question correctly, in a typical face-to-face physical therapy assessment, you would score how strong someone is on a scale of 1 to 5, I think it is. And essentially, it's a subjective measure, but it's one that is based on a great deal of clinical experience. What we're hoping we can do is to replace that measure by a quantitative measure using standard units, newtons, kilograms, if you like. And the work we've been doing is to translate that EMG signal into a force signal. So there's basically a formula that links the two that enables us to express little tiny voltages your muscles generating into force measurements in newtons. And so the work we've been doing in this is showing great promise in terms of being able to make that kind of measurement. Why is that helpful? If you think about it, a scale of 1 to 5 or 0 to 5 gives you 5 or 6 different levels. That's the granularity of your measurement. When you're using something that is a continuous measurement, it gives you much more sensitivity to change. So if you see a patient this week and next week and the following week, if you have more sensitivity to change, you'll be able to see if small amounts of progress are being made or whether we're losing ground much more sensitively than you can using a 0 to 5 scale. So that's one of the reasons for doing it. Another reason is, what if you see a different therapist next time? Are they both calibrated on their 1 to 5 scale exactly the same? And to some degree they are, but this would improve the consistency across clinicians.
Perfect. Okay, I have a couple more there. I just wanted to, going back to the privacy thing, kind of just a statement there, that the AHS Zoom, like Beta was talking about, meets the privacy requirements for AHS and is HIPAA compliant. So it's pretty rigorous. And so anyone who signs into AHS Zoom, it's safe and it's secure as well. So I just wanted to mention that.
And we're using the same Zoom in what we're doing. Yeah.
Perfect. Okay.
And there is also a template, Emily, about like clinicians who are doing the virtual assessments that you can use in the electronic medical record. That is kind of the process that you go through each patient before, like when you start an encounter, explaining them that this is the same safe space that will be like in an in-person regular meeting, and of course you give them the chance of withdrawal, or if they feel uncomfortable at some point, they can do that. So there is a process already in place as a recommendation within our organization to do that, to cover that. That's another aspect of the ethical implications of this.
Perfect. Thanks for that, Pedro. Okay, so we have another minute, so we'll try to get a couple more in. Are you trialing the technology with users who have dementia?
We're not at the moment. We're certainly not ruling that out. We need to make sure that that some of the complications associated with dementia, which part of would be the patient's anxiety that might be raised in using technology, that we manage that as a separate situation from trying to get the technology to work to make a measurement for, you know, a functional assessment rather than one that's a cognitive assessment. So Beta, I don't know if you do any work with cognitive assessment using
or virtual. Yeah, no, I have done some, like not for dementia, but just like a regular, for example, MoCA or mini mental. The problem is that there are pieces of that in which the patient needs to do stuff. And it's a little bit, if the patient is not prepared, so for example, asking someone to do trails or to write a sentence, if they don't have a paper right there, or if they don't have the form with them, then the measurement is incomplete. I think that's a very good comment. Cognitive assessment I think there is potential to do it, but we need to think about how we can use technology to do some, because some of these tests requires for the patient to do something specifically. So I'm thinking, for example, maybe something that the patient could do on the screen or something like that, some technological development that can help us to validly apply these instruments. I think that's a very good comment.
In a slightly different way of doing this, there are examples of using these kinds of technologies for people with dementia who are living in a semi-independent setting where the technology can be used as a prompting device. So if they're needing help to remind them to do something or to keep them out of danger, you've left the stove on or the tap is still running. Those kinds of technologies have been developed. So it's a different kind of world in the sense that this is the smart home world versus the tele-rehab world. But actually, the technologies are very similar.
Yeah, I have two comments I got on that discussion. So one of our clinical leads would like to add that in the wheelchair module, there will definitely be folks who have dementia in that one. And then a comment from someone from AHS. There's work being done around the validity of cognitive assessments virtually. So, okay, let's see. What do you think are the major areas for research in virtual health?
Well, I'll start and say, I think a lot of people say, can you demonstrate how different the outcomes would be between doing a virtual health assessment versus an in-person health assessment? And I think that's an important thing to study. But my reservation is you can only really make that comparison when the technology has reached a basic level of maturity. So if the technology is still in the process of development, it's really not fair to say, okay, now is the time to see how good you are. Much better to say, let's get it to a point where we can say, I think we've got it. and then see how it does against an in-person assessment. So there's a bit more technology maturity needed before I think we do that kind of measurement. Another thing, I don't know whether you would call this research, I think it is in my book, and that is we need to start establishing best practices and standards for doing this so that there's consistency and the best possible quality of assessment. And I think that a lot of work needs to be done in helping us to nail down those best practices in this area because it's so new.
And to add to that, I think the patients, or sorry, I'm calling them patients because in this meeting I'm wearing the hat of the clinician, right? But so the patient's experiences and voices should be integrated in the development of those guidelines. Otherwise, this is not going to go further, because if they don't have the buy-in and if they don't find the value on doing this, as Dana has found, this is not going to go. This is not going to move very far, right?
Yes, very true. Okay, so I think we'll just do this last one here. Is Alberta ahead of the rest of Canada in terms of virtual health?
Mm-hmm.
What do you want to say, Beto?
I don't know. I have heard experiences from Ontario. They are using mainly phone, like phone calls for following up with people with COVID and people in isolation. I haven't heard, but I'm sure that they're using telehealth as well. But I don't know if there is some some research group doing the innovations that Tele-Rehab 2.0 is doing, Martin. I haven't heard, but maybe they are. No?
Yeah, we don't want to be too boastful, but we think we, at least in this project, we're definitely pushing a frontier. But the challenge is going to be, can we sustain it? And I think that the honest answer to that question is actually going to be provided 2 or 3 years from now, when we look back and say, well, you know, back in COVID, we really made some great progress, but look at how far we've come now. And if we don't achieve that, then I think we will probably be left behind, because internationally, this is now a priority. And so I think we could maintain our competitive edge, but it's going to take a lot of hard work to do that.
Totally. Okay, so that's all the questions that I'm seeing there, and it's 5:36. So once again, thank you everyone so much for coming. Thank you to the speakers. It's so wonderful to have had you, and we look forward to being in touch with all of you. Thanks.
Thank you.
Thank you.